Hi there, fellow COVID warriors. Happy Friday. Today is Friday, May 1st, 2020, and this is the Regions EMS COVID update. Information presented is current as of what we know today. Stay tuned to our website at regionsems.com. Click on the COVID link and you'll find a page full of resources that we review on a regular basis. You can be sure that that page is giving you the most up-to-date and correct information that we have available to us. Let's talk about some data. As we're heading into the weekend, we're starting to see a little bit of an uptick in emergency department cases, a little bit of a sicker patient population. We are seeing a slight increase in the number of COVID suspected cases that we're seeing as well. So I don't know if that's just because the weather's nice, people are getting out, getting tired of quarantine, starting to interact a little bit more. But we'll see what the weekend brings. We'll see what next week brings. But we may be starting to get towards our peak here, at least in Minnesota. Worldwide, just over 3.2 million confirmed cases, with about 234,000 deaths related to COVID-19. Here in the US, we've hit the 1 million case mark, and we have about 60,000 confirmed deaths. Minnesota, with the testing increases in the last week, has taken a jump. We're up to 5,136 confirmed cases, with 343 deaths related to COVID-19. In Wisconsin, 6,854 confirmed cases, with only 316 deaths. So Minnesota is surpassing Wisconsin in the number of deaths, and that is definitely not a contest that we want to win. And we're approaching in the number of confirmed cases because our testing availability is increasing quite a bit. So stay vigilant, continue to review our recommendations, work with your city's emergency operations center, your agency leadership to make sure that you are protecting yourself and protecting others as best you can. Several developments this week that I'd like to highlight. First of all, again, don't forget about ECMO. ECMO is still open for business. They are still accepting appropriate patients. They are only performing ECMO at the University of Minnesota right now, so they will not be responding to Regions Hospital. Just keep that in mind. And you will be speaking with the on-call ECMO lead physician, either Dr. Yiannopoulos or Dr. Bartos, when you call the ECMO number, which you can see on your screen right now. Again, call them early, and you want to get moving early if your initial rhythm is shockable and you think your patient is eligible. Get on the phone, talk to the ECMO doc, and get the process moving. Had some really good saves despite the COVID current pandemic right now, so it's still a very good option for those patients in refractory shockable rhythms and cardiac arrest. Most of the EDs now are going to require that not only should you be wearing a mask, but the patients should be wearing a mask anytime a patient enters the ED for any reason whatsoever. Healthcare facilities are requiring that everyone be wearing a mask when they're in the facility for any reason. So every patient needs to be masked with a simple face mask, and every crew member needs to have at least a simple face mask on. I know a lot of you are using N95 masks on a daily basis, and that's fine. That's obviously better than a simple face mask. But at a minimum, simple face mask worn at all times. And you should be wearing those all the times during your shift anyway, so hopefully that's not an issue for you as the healthcare providers. There's been some discussion, at least at Regions Hospital, around aerosol generating procedures, and with the increase in community prevalence, especially in the congregate living facilities, there's some patients that we just have to assume that they're COVID positive until proven otherwise, even if it's for something totally unrelated like a hip fracture or chest pain or something totally unrelated. So with that, what are we doing about airway management? How are we pre-oxygenating these patients? How are we bagging them if they need ventilatory assistance? Are we using nebulizers? Are we using CPAP? Each hospital is going to have to make that decision for themselves, but I just want to be very clear that we are not in crisis mode yet, so we are not altering our standard of care in a way that might cause harm to patients. So we still recommend the use of nebulizers when indicated. Just try to avoid doing them in the back of the ambulance. Do them outside whenever possible. We are still recommending CPAP if indicated. We are still recommending using airway devices such as the iGel when indicated, and if the patient truly needs to be intubated, endotracheal intubation, RSI, whatever, we should still be doing that. The caveat is that all of those are considered aerosol generating procedures. Aerosol generating procedures bring us to a higher level of PPE needed. And we should be doing this for any of these interventions regardless of what the initial suspicion for COVID is with the patients. We need to treat all cardiac arrests, all major resuscitations, critically ill patients, airway management as COVID suspected, and wear the full airborne precaution PPE. That includes an N95 face mask, eye protection, ideally a face shield, gloves obviously, and a gown. So make sure that you're wearing full PPE anytime you are performing an aerosol generating procedure on a patient. In addition, we should also be using viral respiratory filters in line with the bag valve mask on the exhalation port of a nebulizer kit, and if possible in line with the CPAP system to try to filter out any viral particles that might be exhaled out into the atmosphere. This is critical. Obviously, we have to do the right thing for the patient if those are not available, but please, with your agencies, with your leadership, work to make sure that you have those HEPA filters or the viral inline respiratory filters. Contact our office if you're having issues obtaining those, and we'll see what we can do to help you out. I'm going to post on our COVID page a link to an article on a website called First 10 EM that talks about aerosol generating procedures and does a nice review of the very limited evidence that's available on those procedures and how they increase or don't increase the risk of disease transmission to other people in the area. So just kind of a good overview of what are the risky procedures that we perform, and I'll give you a spoiler, endotracheal intubation is going to be probably the most riskiest procedure that we perform as far as the risk of spreading the virus to other people. But hopefully an interesting read provides some good information for you. Again, I can't emphasize the use of full PPE enough, especially for these aerosol generating procedures. First thing you need to do is get a mask on the patient. You should already be wearing a mask, so that should not be an issue. Right there, you've limited the maximum risk of any exposure that you might have with that patient. For aerosol generating procedures, you need to make sure that you have full face protection, eye protection, N95, and contact protection, so gowns are important in those aerosol generating procedures. Just a refresher to congregate living facilities, so that includes nursing homes, prisons, group homes, even assisted living facilities, any place where there's people living in close proximity that do some of their daily activities together, such as eat in a common dining area or interact with each other regularly. At this point, this doesn't necessarily include regular apartment buildings, but obviously if there is some sort of common cafeteria in that building or some sort of care staff that's making rounds on people in that building, then that would be considered a congregate living situation. The numbers are just too high, and those patients are just at too high of a risk. So we need to treat all of them as if they're suspected COVID until proven otherwise, and we're not going to prove otherwise in the pre-hospital phase. So any patient from any of those facilities, regardless of their chief complaint, needs to be treated as COVID suspected. This probably shouldn't really change how we're managing this anyway, because what that means is you're going to put a mask on the patient, and you need to be wearing a mask and ideally eye protection at a minimum. And then again, if you're doing any aerosol procedures, then you upgrade to the N95 and the gown. But the hospitals are doing that. They're treating all congregate living patients as suspected COVID, so we need to extend that out into the pre-hospital phase as well. Also, we have to also understand there are differences in our environment in the pre-hospital phase and the hospital's environment in the ED phase. They are in a fixed facility with rooms that need to be recycled and reused for other patients. We have our ambulances, but generally when we're interacting with our patients in their homes, we're not going to necessarily be reusing that same space for other patients, hopefully, in the future. So even if there's particles that get suspended in the air, there's plenty of time in a private residence for those particles to, we're not worried about the ongoing risk of those suspended particles to us or to other people necessarily, because they've already been there in that space. In the hospital, there is some concern that those particles may be suspended in the air for hours, possibly, and that just increases the risk of transmission to other patients that might be in that room. All that said, you may be asked to discontinue certain aerosol-generating interventions before you enter the ED. The main one that we're talking about here is CPAP and nebulizers. So don't be offended, don't be alarmed if the ED asks you to turn off the CPAP or stop the neb before you enter the ED. I think that's very appropriate for that transfer point from the ambulance into the hospital room, and then let the hospital decide what they need to reinitiate once the patient gets transferred over. All right, so just be aware of that. We have been in discussions with hospitals about how we're going to interact with the EDs with those specific types of procedures. I think that's all I have for today, as if that's not enough, right? Heading into the weekend, supposed to be another beautiful weekend, so get outside, social distance, enjoy the beautiful weather. Let's stay vigilant, prevent the spread of the virus as much as we can, and continue to flatten the curve. Back to Tuesday's trivia question. So which bar owner-operator in Nashville initially refused to cease operations when the mayor ordered all bars and restaurants to close? Shout out to Chris Zuley from Stillwater Fire, Joel Schmidt from White Bear Lake Fire, Brian Mueller, steady submissions from Washington County Sheriff's Office, and then Andy Fossum and Tim Deans from MRCC. We're all correct. It was Kid Rock. Had to be Kid Rock, the guy who's going to buck the tide, go against the flow. Of course, it's Kid Rock. Let's go on to today's trivia question. Now I'm kind of in the realm where I've used up a lot of the at least the interesting trivia questions that I could find. So I'm going to start making up some questions, and please feel free to call me out if you think that the answers are incorrect, but we'll address the answer to this one next Tuesday. So you have plenty of time over the weekend to submit your answers, your guesses, other questions, comments, feedback, Groupons, Amazon gift cards, whatever you'd like, to regionsems@healthpartners.com. Or any questions, concerns you might have too, and we'll get back to you as quickly as we can with answers or recommendations. Also, again, don't forget to reference our website, as a lot of questions that we get are answered in the frequently asked questions section on our COVID page. So for next Tuesday, which country claims to have eliminated COVID-19? Is it A, Singapore, B, New Zealand, C, North Korea, or D, Wuhan, China? Send your best guess to regionsems@healthpartners.com. Otherwise, stay dry today, enjoy the weekend, and we'll see you next week.